Hello and welcome to today's Center for Healthcare Strategies webinar, made possible by the Commonwealth Fund on coming home and staying there, improving care transitions for duly eligible beneficiaries. Today's webinar is also co-sponsored by the Better Care Playbook. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question and answer session following the presentation. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I'll now turn the webinar over to Logan Kelly, Senior Program Officer at the Center for Healthcare Strategies.
Thank you so much, Travis. And again, welcome everyone to today's webinar, Coming Home and Staying There, Improving Care Transitions for Dually Eligible Beneficiaries. I'd like to again thank the Commonwealth Fund for generously supporting today's webinar. And we have an exciting lineup of speakers today. After some brief introductory remarks, we'll hear from 3 integrated health plans on their innovative approaches to addressing care transitions for dually eligible beneficiaries. First, iCare's Follow to Home program, then Health Plan of San Mateo's Community Care Settings program, and finally CareSource's Care Management Model. After each of these 3 health plans present, we'll have a moderated question and answer period where our presenters will answer questions submitted by all of you during the webinar. So first, we'll start with introductions and brief welcome remarks. Again, my name is Logan Kelly, and I am a Senior Program Officer at the Center for Healthcare Strategies. We're joined today by Tanya Shaw, Vice President, Delivery System Reform at the Commonwealth Fund. Presenters from our featured health plans are Lisa Holden, Vice President, Accountable Care at Independent Care Health Plan, Amy Scribner, Director of Behavioral Health at Health Plan of San Mateo, and Jennifer Anadiotis, Director of Integrated Care Post-Acute Strategy, and Jean Solomon, Director of Long-Term Support Services, who are both with CareSource. And then just some quick background on the Center for Healthcare Strategies. CHCS is a national nonprofit health policy center dedicated to advancing innovations in healthcare delivery for low-income Americans. We work with state and federal agencies, with health plans, with providers, community-based organizations, and other stakeholders to create programs that better serve beneficiaries of publicly financed care, and particularly those with complex needs. And our 3 priority areas are outlined on the slide displayed. And today's webinar is co-sponsored by the Better Care Playbook, which is an online resource center that features the latest knowledge on evidence-based and promising practices for people with complex health and social needs. Resources on the playbook include practical implementation tools that are designed to help health system leaders, plans, policymakers, and other stakeholders improve care for high-need, high-cost populations. The playbook is coordinated by the Institute for Healthcare Improvement and the Center for Healthcare Strategies through support from 6 leading national healthcare foundations, the Commonwealth Fund, the John A. Hartford Foundation, Milbank Memorial Fund, Peterson Center on Healthcare, the Robert Wood Johnson Foundation, and the SCAN Foundation. And you can visit the playbook's website at bettercareplaybook.org. And this webinar features health plans that have participated in CHCS's Promoting Integrated Care for Dual Eligibles, or PRIDE initiative, supported by the Commonwealth Fund. And PRIDE is a learning collaborative of 9 leading health plans, advancing promising approaches to integrating Medicare and Medicaid services for dually eligible individuals. And in the current phase of PRIDE, health plans have partnered with delivery systems to implement innovative care delivery interventions, and these include the programs that you'll hear more about shortly. And in addition to the health plans featured on this webinar, other PRIDE plans include Blue Care, Care Oregon, Commonwealth Care Alliance, UCare, UPMC for Life Dual, and VNSNY Choice Health Plans. And we would like to very much thank the Commonwealth Fund for generously supporting the PRIDE Learning Collaborative since 2013. And now I would like to introduce Tanya Shaw, Vice President, Delivery System Reform at the Commonwealth Fund.
Good afternoon, everyone. For those of you who are not familiar with the Commonwealth Fund, we are an independent foundation that has been around for over 100 years, and we support independent research to improve healthcare practice and policy. Our mission is to promote a high-performing healthcare system that achieves better access, improved quality, and greater efficiency, particularly for society's most vulnerable. Specifically, I cover the high-need, high-cost portfolio, which focuses on delivery system reforms to improve care for the heterogeneous population of adults who have multiple chronic conditions, functional limitations, and often face social and behavioral health issues. Next slide, please. A critical population we want to improve care for are the dually eligible. Today, we have 12 million adults that are both in Medicare and Medicaid, but only 10% are actually in integrated care, where delivery system and financing approaches that maximize Medicare and Medicaid care coordination mitigate cost shifting across both payers. So very few of these individuals are actually in coordinated integrated care. This is also a persistently high-need group who have multiple chronic conditions, at least one functional limitation, and have a high prevalence of behavioral health needs. This results in a concentration of healthcare spending for duals in both Medicare and Medicaid. Next slide, please. As I mentioned, 90% of duals are not in integrated care. This contributes to an incredibly difficult, confusing, and fragmented system of care for these vulnerable and high-need individuals. They experience worse outcomes, such as preventable hospitalizations and readmissions, and often don't experience high-quality coordinated care, despite being high utilizers and having multiple touch points with the health system. So we have a lot of missed opportunity to engage them in effective care management programs if one is offered where they get care. Next slide, please. I'll turn it back to Logan to share an approach. We've been working closely with the Innovative Plans and the Pride Collaborative, and she's going to walk us through this particular strategy.
Great, thank you so much, Tanya. And next I'll share some quick context for why care transitions are so important to address for dually eligible individuals, and they've been a priority area for many of the plans participating in the Pride Initiative. And when we use care transitions in this webinar, we mean transitions between different settings of care, such as hospitals, long-term care facilities, and home. And these transitions between settings are often accompanied by different sets of providers. And there's extensive evidence that poorly managed care transitions can result in reduced care quality and increased costs. And during these transitions, dually eligible individuals are especially vulnerable to adverse health outcomes, potentially avoidable hospitalizations, and poor care coordination. And often these transitions mean that coverage switches between Medicare to Medicaid as the primary payer, with different providers in charge who might not speak to each other. And dually enrolled individuals must navigate separate benefit coverage and providers at the same time that they're adapting their care plan for a new setting with different types of available supports. And transitions are also at the center of state and health plan initiatives to support individuals that are moving out of nursing facilities and into preferred community-based settings. National trends show an increasing amount of all spending on Medicaid long-term services and supports go to home and community-based services, as opposed to institutional settings like nursing facilities. But that proportion varies by state between less than 30% to more than 80% of spending. And that variation really shows that there is still a lot of work to be done to support individuals who do not want or need to be in institutional care in transitioning to community settings. And these programs featured on today's webinar are examples of high-quality care transition support, and those transitions from either hospitals or nursing facilities to community settings. Health plan presenters will share how they identify the members who need supports, how they work with delivery system and community-based partners, and how they address the needs of members with housing insecurity to achieve the aims that are outlined on this slide. And recent evidence shows the impact of transitional care interventions on both care quality and utilization, and this includes dually eligible beneficiaries who have LTSS needs. And notably, in part due to increased federal, state, and industry focus on reducing avoidable hospitalizations, between 2010 and 2015, the rate of potentially avoidable hospitalizations for this population living in long-term care facilities decreased by over 30%. And the Community-Based Care Transitions Program, which was part of the CMS Partnership for Patients between 2012 and 2017, produced evidence that targeted transition services could significantly lower hospital readmissions and Medicare costs for high-risk Medicare beneficiaries. One crucial component of these services is information sharing when new admissions occur, especially to share information on Medicare-covered hospital and skilled nursing facility admissions with the entities that are coordinating Medicaid-covered long-term services and supports, and that's in order to initiate care management activities in a timely fashion. And then following from that evidence, there is a new requirement for dual-eligible special needs plans, or DSNPs, that do not already cover Medicaid LTSS or behavioral health services to notify the state on hospital and skilled nursing facility admissions in order to improve coordination of Medicare and Medicaid services between care settings for this population. And selected states will need to include this requirement in DSNP contracts in calendar year 2021. And in the footnote, there's a link to a brief recently published by the Integrated Care Resource Center on state considerations related to this requirement. And now I would like to welcome our first health plan presenter, Lisa Holden, Vice President of Accountable Care with Independent Care Health Plan.
Thank you, Logan. I am really happy to be here today to talk with all of you about a program that started 2 years ago. But first, a little bit about iCare. We are located in southeastern Wisconsin. We serve only a dual-eligible population who are also Medicaid covered, SSI, Badger Care. These are Wisconsin programs, and we have a long-term care program. So we are really committed to working with low-income individuals and those who have disabilities. So a couple of years ago, we were really struggling with some of our financial data analytics that were telling us that we really were not effective in reducing high inpatient costs and in particular in preventing readmissions. We had had a 30-day program for quite a while, but even that program, which was high touch, still generated over 20% readmissions, and we just weren't satisfied with that. So what we did is we got together, and this was prior to 2017. It took us about 13 months to design this program, but we got together and said, look, what do we know works? And we know that high touch works after a discharge. Who the high touch should be provided by, we came together and decided we really felt that home health agencies would be the best equipped to provide that high touch after discharge. We also worked with a nurse researcher who said, look, Lisa, I've looked at your data. Your 30-day readmission prevention isn't horrible, but look at 60 and 90 days. You've got a lot of readmissions happening between that 31-day post-discharge and 90. So you need to do something a little bit different. And I was really grateful for that feedback. The same nurse researcher introduced us to a nurse practitioner specializing in geriatric care who had participated in a study to determine the impact of nursing when provided in the home after transition out of a skilled facility. So she came in with a lot of experience, and we sat down and began to craft this program. So what is the follow-to-home model? Well, the model is offering post-discharge nursing support in the home for 90 days. We contracted with home health agencies to provide what we call nursing case management. Now, some of the agencies didn't understand what in the world we were asking for. They said, are you talking about skilled nursing? No. Okay, you talking about medication management? No, we're not. We're talking about case management services. And we said, tell you what, we're going to create an alternative payment model with case rates and bonus incentives. And we're not going to offer this to every single discharge. In fact, what we want to do is offer this just to those members who we screen to be high risk to readmit. So as I mentioned a moment ago, when we approached two of the larger home health agencies, they really couldn't grasp the model. It didn't make sense to them. But that was okay. We went to other agencies who readily accepted the model and said, yes, count us in. Let's start small. Let's make it a pilot. But let's see what we can do. We think you're right. We think your hypothesis is correct. So let's see what will happen. So we said to them, well, tell you what, we want some specific information from you when you conduct the first home visit. So again, the members admitted to the hospital, our discharge planning nurses conduct a readmission risk assessment based on the member's history as well as the condition at the time of the admission, and they determine someone is at high risk to readmit. We then refer that member to the home health agency, and now at this point, 2 years into the program, each of the agencies have assigned a small group of nurses to do this program with us. So the nurse receives the referral, and the first point of contact ideally happens within 72 hours after discharge. We like it even better when it's 24 or 36 hours after discharge. So the nurse goes into the home, and we ask them, please do an environmental home assessment. Tell us the condition of the home. Are there working appliances? Are the utilities working? Does the member have access to a clean environment? Is it cluttered? Is this a hoarder that we have to be concerned about? So they go through all of that. They then complete a medication reconciliation and the good old-fashioned kind. Show me all your pills, show me all your bottles. Can I open your cupboard doors? I really want to understand what you're taking and how the degree to which you understand your medications. So they take their time. They also look at the durable medical equipment that's been delivered. Has it been assembled? Does a member have any idea how to use it? They look into that. And then finally, they make sure that the appointment is scheduled with their primary provider or the specialist who saw them in the hospital and wants to see them post-discharge, and we make sure that that appointment is scheduled. We also at iCare use the patient activation measure survey. So we ask this home visiting nurse, please complete that 10-question survey to give us an idea of where the member is as of this discharge. Because at this point, we've got their PAM survey score previously, but we want to see if there's been a shift because of this admission. And then we get the reports back. They fax over to us 5 pages. We look at what they've documented, and we say to them, great, we are going to have a weekly call with you, and we want you to tell us how our member is doing. And that's where this program gets really, really interesting. We do not say to the home health agency, you must visit the member X number of times. We do not tell them how often to be in contact. We actually don't tell them what to do. We say, all we're requiring you to do is to be on a phone call with us every week to tell us how the member's doing. So what does the home health agency get in return? Well, we pay them a flat rate for that first home visit in the member's home. And then, as I mentioned at the beginning, they get a case rate payment at 30, 60, or 90 days. The further out the member goes, the more they get paid. If they make it to 90 days, they get a bonus. And as of right now, we have 8 participating community-based home health agencies covering 10 of Wisconsin's counties. Now, you're wondering, okay, how does this work? Well, the outcomes we've been collecting from the beginning, but I want to share with you 2019 outcomes. So our outcomes show us that we had 379 referrals come to us from our discharge planners and sent out to the home health agencies. Of those, 189 were able to complete assessments. That's about a 48% completion rate. And I'll talk in a moment about why that's not higher. We are delighted to share with you that at this point, and this has been consistent from the start, nearly 50% of the members do make it all the way to 90 days without an admission or a readmission. I kind of said that backwards. A readmission after within 30 or an admission between 31 and 90. Right now, in these numbers, we still have people that are in the program that's 42 of them in, and we also have 12 where the agencies are currently trying to locate the member. So you're going to wonder, what is the return on this investment by iCare? Well, it's actually quite astounding. When our financial data analytics team began to look, they said, well, you know, we want to track claims behavior basically prior to the admission, prior to the program, and then what happened afterwards. They looked at 6 months and they looked at 12 months. And when we looked at 12 months, we started with the first 83 members in the program and said, okay, what happened to their cost 12 months prior to follow to home and 12 months after? And we found, astoundingly, a net savings of over $1 million. And we thought to ourselves, wow, that is far better than we thought it would ever be. And we really had to ask ourselves, why is this program so successful? And what I really want to share with you is that what makes this program successful is the dedication by the home health agencies. When we have our weekly calls with them, they are able to provide us with detailed accounts of every member they're following. So we talk to each agency separately. We will talk to, let's say, agency 1, and that nurse or nurses will come to the call and say, let me describe to you the 10 members that I'm following right now. So even though we don't tell them what to do, they're staying in contact with the member. We've heard stories where they'll say, I just had a hunch that my member was beginning to get worse, so I decided to make a home visit on the weekend. I happened to be in their neighborhood, and sure enough, they were starting to have a need, and I was able to address it. That's not an uncommon report that we get from the home health agency nurses. They understand the model, they are dedicated to it, and they've shown us that as we have needs increasing, they're able to step up. So the program is easily scalable, which again has been another very, very pleasant learning from this. So I want to go on and talk with you about, so now that Follow to Home is working, what else have we decided to get into? Well, we have, as many of you I'm sure who are listening to the webinar, we have challenges addressing the needs of our members with mental illness, behavioral health, and also our members that are homeless. So in addition to Follow to Home, we have now a program called Follow to Community. We have a program called Follow to Home for Homelessness, and in the near future, we will have Follow to Home after a skilled nurse facility stay. Now, these models aren't all identical. We're trying different things, but with the Follow to Community, what's exciting is that we have a case manager from a local nonprofit who is going in while the member's still in the hospital, meeting with them, introducing the program and engaging them, and then asking perhaps the most important question, where do you think you'll be going on the day of discharge? Now, the program is young. I don't have any ROI for it yet, but we're very excited about this prospect of going into the hospital and allowing the member to see the person who's going to stay in contact with them after discharge, so that we can really establish an agreement. And when I talk about the homelessness population, what we know better than anything is simply to be okay with whatever the member tells you. So we've gotten very good at saying to the member, where do you think you're going when you go home? And what is home for you? And if they begin to say what they think we want to hear, oh, I'm going back home to my friends or to an apartment, we say, well, how long have you lived there? Oh, okay. Is it stable? Have you been there a long? Oh, you're staying with a relative. How long do you think you're going to be with that relative? And then we ask them to negotiate a little bit with us. Say, tell you what, we're going to give you our phone number. We want you to call us if that living arrangement doesn't work out, because the Follow to Home nurse has to find you. So how about if you just tell us where you think you're going to be, and we'll meet you there? What has that ended up with? We've met people in cars. We've met people in tents along the river. They are becoming very familiar with us, meaning there's a homelessness community that the word is out. If you're an iCare member and you're leaving the hospital, they will come and meet with you wherever you are. And that's been very, very powerful for us. We've been very pleased. So I'm going to stop here and honor the time, and thank you very much for listening.
Great. Thank you so much, Lisa. And I'd like to remind participants that if you have any questions about the presentations, please ask them in the Q&A, and we'll answer questions for all panelists after each of the three panelists has concluded. And next, I would like to welcome Amy Scribner, Director of Behavioral Health at the Health Plan of San Mateo.
Great. Thanks, Logan. All right, so today I'm going to be talking about our community care settings program. So just a little bit about Health Plan of San Mateo. So we're located in San Mateo, California. Health Plan of San Mateo was created in 1987 to address access to preventative care for Medi-Cal beneficiaries. We are our county organized health system. And so when we started back in 1987, we had 28,000 Medi-Cal recipients, and today we serve 130,000 members. So in terms of the community care settings program, one of the things that happened was in February of 2013, we had approximately 1,300 members residing in skilled nursing facilities. At that time, we learned that the largest skilled nursing facility in the county was planning to close in June of 2013. We found very limited capacity within the county to absorb the patients expected to be displaced by this closure, and an initial needs assessment of SNF residents across the county revealed that anywhere from 10 to 30% of our members in skilled nursing facilities could live independently with the right services and supports in place. So with this data in mind, and then the creation of our CalMedi Connect Duals Demonstration Project, we launched the Community Care Settings Pilot, or CCSP, to address the challenges and opportunities presented by these circumstances. So as you can see on this timeline here, it's been a long road for us to get to the point that we're at now, with many additions along the way. So we initially did the needs analysis, market research, the decide of do we build this internally, or do we put it out for RFP and see if other places are doing that. We decided to do the RFP route. And then in 2014, we contracted with 2 providers, the Institute on Aging and Brilliant Corners, and created the program design. Along the way, in late 2015, early 2016, we transitioned our first 100 members integrated within whole person care. We got whole person care funding in San Mateo County. In 2017, we reached 150 members transitioned and added various levels of care management, which I'll talk about in a few minutes. And then as of today, we've actually had 292 transitions in the total life of the program. So the initial program objective was to provide the greatest opportunity for members to return to or stay in the community with the highest quality of life, reduce our overall utilization on long-term care, generate savings by reducing healthcare expenditures for this population. And we did this through a package of both intensive transitional case management and housing support resources that were designed for both the folks who were currently in long-term care or skilled nursing facilities or at risk for nursing home or skilled nursing facility placement. And so these initial program objectives still apply today. We really strongly believe that a comprehensive package of housing support, and case management lead to the greatest success. So one of the things that I feel so fortunate about working here at Healthplan is that the member really is at the center of our care. So we always have the member in mind and are helping to direct the members through a very complicated system by linking them to needed services and navigating the system. So as I talked about a little bit in slide 4, we have 2 partners, the Brilliant Corners and the Institute on Aging. So Brilliant Corners does our housing search, assistance with affordable housing applications, housing retention services, and they actually have a direct contract with the Housing Authority. And then on the other side of intensive case management, the Institute on Aging provides assessment and facilitation of needed goods and services to support the transition or prevent unnecessary institutionalization. It's an integration of a medical, social, and behavioral health services and supports, and we now have a phased approach to care management. On the Brilliant Corners side, one of the great things that has happened is housing in San Mateo County is very expensive. Land and space is really limited. And Brilliant Corners has been successful in leveraging existing relationships to expand the network of landlords who will accept Section 8 vouchers. And then on the Institute on Aging side, the Institute on Aging actually manages a network of licensed boarding care homes, or RCFEs, in which a large number of our members are placed. So we've had this program since 2014, so we have a lot of really robust data and information. So the primary evaluation is a biannual program evaluation by a third-party vendor. And so monitoring the success of the program has been crucial. With this vendor, we do a pre and post intervention analysis. We take the total cost of care by target populations, 6 months pre-transition to whatever housing opportunity or home they go to, and then track 6 months post-transition. We also do a longitudinal evaluation. The analysis is based on actual claims data. It includes county-administered programs like in-home supportive services and behavioral health. The important thing to note about this is that this methodology does not capture cost avoidance from avoiding institutional placement for the folks who are non-long-term care or who are in the community who we're serving through this program. The second piece of evaluation that we do is we get quality operations reports, and these are great ways for us to track process, timeliness, and access metrics. We also get biweekly dashboards so we can visually track program information to date. And then another important piece is our annual satisfaction surveys. So we have 2 different surveys that go out. The first one is the client satisfaction survey, and the second is the stakeholder satisfaction survey. The results of these surveys are discussed in our operations team, successes are celebrated, and opportunities for the year are identified. Of note, overall member program satisfaction and net promoter scores are consistently high. So some of our program outcomes. So on the left-hand side, you'll see that this is the pre-cost, so 6 months prior to the person transitioning to wherever they're going, and then the 6 months post. We see a pretty amazing savings happening, and you can see on the right there are different buckets that these costs get put into. 93% of all clients are still in the community. We see a 96% decrease in SNF costs. And there's high enrollment in our LTSS programming, which supports ongoing community maintenance. So just of note, our program has demonstrated effective reduction in total cost of care. However, program costs are not reimbursable by our state rates, and instead may contribute paradoxically to our state premium. This program is a strategic investment for Health Plan of San Mateo because it's the right care model for our members. We do leverage our care plan optional dollars in the dual population, and on the horizon there's the possibility of the state including these as part of an in lieu of services proposal through CalAIM. So we've had a little time on this program, so we have some lessons learned. On the first one, allowing for program ramp and evolution. So as you saw in the timeline slide earlier, an RFP and idea or model gets created, all systems are a go, but then the plan for implementation can be slow with constant PDSA cycles along the way. I think what's really important is to find a partner who's willing to adjust to the changes as needed and spend time investing in and cultivating the relationship. It will pay dividends in the end. Through this program, we've been able to fill systemic gaps and break down barriers to support transitions and community longevity. So by identifying and utilizing the resources, we've been able to be creative, investing in innovation to support the community living. So if it means we need to help financially pay for a caregiver while they're getting their in-home supportive services, we're doing some home modifications to make the environment safe and accessible, or providing transportation to housing appointments so that they can secure long-term housing. The third one is the focused and flexible housing approach. So through this program, we've been able to develop a range of housing options, not just a one-size-fits-all model. Over time, new relationships have been created as a result of this model. We've leveraged the Coordinated Care Initiative to innovate and create new partnerships. So in our housing portfolio, we have licensed boarding care homes. We have senior set-aside units, Section 8 housing, and then we have independent apartments. And then on the last thing, that carve-outs and program restrictions require upfront investments and improved coordination. So here, various services such as mental health is carved out of managed care plans. As we know, housing is carved out and community-based services. So Moving forward, full integration would better align plans to serve their members' needs and provide financial resources to pay for treatments and services. So just wanted to share a little bit of a member story. This member actually recently came to our commission and spoke to our commission. So this is Kojo. In 2014, he was hospitalized for a stroke. He was paralyzed and diagnosed with expressive aphasia. Following his hospitalization, he went to a skilled nursing facility for rehab, but plateaued and got stuck with no place to discharge to. In early 2015, he enrolled in CCSP and moved from the long-term care facility to a large boarding care in the network. Kojo has lived there since 2015 and it is home. He attends an adult day health program and is happy now and has a lot to live for. So he has a little quote at the top: "When I met my CCSP social worker, it was like she opened the door and let me in." That's all I have on this.
Great. Thank you so much, Amy. And I would just like to remind everyone that if you have questions for Amy on CCSP, then please ask those questions at the Q&A icon at the bottom of your screen. And also, if you'd like to download the slides that all of the presenters have shared, there are links to download those slides if you click on the chat icon. And with that, we'd like to transition now to our final plan speakers who are from CareSource. So I'd like to welcome Jennifer Anadiotis, Director of Integrated Care Post-Acute Strategy, and Jean Solomon, Director of Long-Term Support Services.
Good afternoon. This is Jean, and I will begin the presentation. The title of my portion is Transitions, What Matters Most. And I'm going to ask you to stick a pin in that "what matters most" phrase because we'll be coming back to that. So next slide and the next slide. So CareSource is a nonprofit managed care plan that has been serving low-income persons for about 30 years. We operate across several states and markets and are currently serving just a bit over 1.8 million members. Next slide. So caring for an aging and complex population is a difficult challenge, as we all know. So our CareSource Dual Eligible project, also known as MyCare, has strove to embed national standards and best practice models into our case management program. And this platform includes Case Management Society of America standards, the Care Transitions Intervention Program, and the Institute for Healthcare Improvement Age-Friendly Health System, or otherwise known as the 4M model. And this model is really a clever and simple way to bundle and remind our case managers about the health and psychosocial concerns of older adults. And because the 4M model is really so very fundamental to how we approach care, I'd like to briefly review the 4Ms. The first is what matters most, and this refers not just to member-centered care, but truly member-driven care. And we find the concept really extremely critical to successful aging, and one that can significantly improve the experience of care as well as reduce costs. And the concept of what matters most underlies all of our care planning, as well as transitions across care settings, advanced care planning, and end-of-life decision-making. The second M, medication. We're all aware that older adults are often prescribed just way too many and high-risk medications, and there can be significant discontinuities of medications during transitions. The effects can include exacerbation of cognitive challenges, adverse drug events, just to name a few, again, interfering with health and quality of life. The third M is mentation, and this refers to cognitive affective disorders, including suicide and dementia-type illnesses, which are prevalent in the elderly and chronically ill. So screening and assessment is imperative. And then the fourth, mobility, reminds us about the devastating consequences of falls and the importance of maintenance of function to live as independently as possible. Next slide, please. So MyCare consists of 3 prescribed populations, which includes long-term care nursing facility residents, the waiver members receiving home and community-based services, and the community well population. And CareSource has added a 4th, being a dedicated behavioral health team that provides primary case management for severely mentally ill members, including substance use disorders. The community well population represents about 65% of the total membership, and the goal is to prevent illness progression or a change in healthcare condition. And early into conceptualizing the MyCare model, CareSource collaborated with the area agencies on aging as an essential health partner in the delivery of long-term services and supports. We understood that the AAAs knew many of our future enrollees and were subject matter experts in helping members age in place in the community. And indeed, partnering with the AAAs and other community organizations was and continues to be essential in delivering one of the most common what matters most, which of course is how to age in place in the community. Next. So the question became, in a population of 17,000 community well members, how do we consistently identify those at high risk, especially during transitions, and those that may benefit from home and community-based services? And what tools could we offer the case manager to support the process? So our efforts began to focus on developing a waiver screening tool, a brief screening tool, which was really a subset of state eligibility criteria to be administered by our case managers during an already very robust significant change event assessment process. Again, with the goal of identifying members at high risk or in need of additional support in the post-acute phase, improving quality measures, preventing chronic illness progression, enhancing member satisfaction, including what matters most, and lowering overall costs. In addition, we had early on recognized that transitions, particularly between levels of care, are significantly complicated from an administrative and clinical perspective, especially when using vendors. So detailed workflows, which are consistently reviewed and updated, is critical in terms of guiding the process and avoiding gaps in care. And when a community well member is identified as needing a waiver of level of care, he or she is actually assigned to a AAA case manager who provides both waiver services as well as the MyCare prescribed case management activities going forward. Next slide. So we're relatively early into this new screening initiative, but even when mature, it may be difficult to sort out the contributions of all of the in-flight initiatives on outcome measures. So we're looking at what we call lead indicators, which is a concept taken from the 4 disciplines of execution. And lead indicators are those things most connected to goal attainment over time. So if the goal is one of reducing admissions and readmissions in the community well space by ensuring that members have post-acute support and or are in the correct level of care, then we can audit for the use of the new screening tool and track the number of referrals made for home and community-based services and the number of members actually converting over time. So we are preliminarily seeing a modest positive trend in referrals being made to waiver and a more vigorous uptake in regard to waiver eligibility determinations. Approximately 85% of the community well members who apply for waiver meet the enrollment criteria, and annually between 4 and 5% of the community well population actually successfully enrolls onto waiver services. In terms of lessons learned, we would like to have introduced the screening tool earlier to formally structure the process and as a reference tool for new case managers and to ensure more consistent identification of high risk and need for a higher level of care. We've also learned that significant care must be taken in establishing and maintaining relationships, especially with delegated vendors, and this takes significant and ongoing work over time. And finally, building on a care platform that promotes a member-driven and safer system that can prevent avoidable harm and improves the care of people with complex care needs is essential. And we remind ourselves all the time that what matters most is really the most important idea that we can support to honor our members, their families, and caregivers. And now I will turn the presentation over to Jennifer Anadiotis.
All right, thanks, Jean. To follow up with what Jean shared about our populations within the MyCare program, the second area of care transition focus in the MyCare program relates to assisting our members who live in the nursing home setting to return to community living, or what we refer to as long-term care rebalancing. The focus of long-term care rebalancing is to support transitions for our members who have lived in the nursing home setting for 100 days or longer. The case management team actively works to identify and assess members who have a desire and the ability to be discharged from the nursing home to the community setting. As a result, the case management team then works closely with the identified members, their support systems, and the nursing home staff to develop a safe transition plan, which may include referrals to home and community-based services and supports, which would be inclusive of assisted living resources, personal care services and home care services, referrals to available state programs to support finding housing, assisting with moving and associated expenses, and retraining on community living skills, which is an important thing that we'll touch on here briefly in a moment. And then evaluation and referral for needed durable medical equipment and or home modifications. Next slide, please. So in order to support long-term care rebalancing efforts, the MyCare case management team at CareSource has developed this transition workflow that really is comprised of three main areas. First, identification and assessment of members. The case managers are using a proprietary screening tool to evaluate the individual's cognitive, physical, and psychosocial needs, as well as the availability of caregivers or other support system resources to help the member successfully transition to the community. This tool is also used to screen for social determinants of health to include the availability of stable housing, financial resources to support community living, access to food, and transportation. The tool is completed annually for all of our members who are living in long-term care, and then as needed based on member goals or other identified changes. The second element that's addressed in the workflow is the development of case management team knowledge of community-based resources that may be used to support a member's transition from the nursing facility. We know that case managers are positioned to understand both member benefits and available community resources, so their knowledge is really critical to help link our members to needed services during the transition planning period. The third element in the long-term care rebalancing process is the use of a dedicated case manager in the nursing facility setting to support the transition work. Our case management model allows for case managers and patient navigators to be assigned to specific nursing facilities as the primary point of contact for members and facility staff. And this model allows for the case managers and our patient navigators to develop strong working relationships with their members as well as the facility staff. This helps support closer coordination of benefits and services earlier in the transition planning process. Next slide, please. So from an outcomes perspective, CareSource has successfully supported approximately 3 to 4% of our long-term care population returning to the community annually. Of that percentage of members who have transitioned, 70% of them have been able to remain in the community greater than 100 days. These members did not return to the nursing facility setting and were successfully receiving their needed services in the community. Clearly, through our process, we have had some lessons learned, and they were important for us to take back and understand to refine our processes. First, we identified that transition planning needs to occur with the involvement of all identified stakeholders. Clearly, just having conversations in isolation between the case manager and the member, or the case manager and the nursing staff at the nursing facility, while important, wasn't reflective of all of the important people that would support a member successfully transitioning from the facility into the community. So we really focused on making sure we identify all of the important folks who needed to be involved, who are going to be actively involved in supporting the member in transition, and work to communicate with them on a continuous basis. We also identified that critically important to a transition is the need for education to be provided to the member and their support system before, during, and after the transition occurs, specifically around medications, treatments, the amount of care that someone needs, the hands-on help that someone may need, and resources so that we avoided adverse transition outcomes. Ideally, we would involve the primary caregivers who would be assisting the individual in the community to come into the skilled nursing facility to learn hands-on how to for example, help someone transfer in and out of a chair safely to avoid injury both to the individual member and their caregiver. It was also important for us to recognize that individuals who have lived in the nursing facility for months or longer often need to relearn community living skills, like scheduling a doctor's appointment or learning how to manage transportation or paying bills or getting groceries. As part of the transition process, we encourage our care managers to identify potential needs and explore resources with the member and their support system prior to the discharge, so that we start talking about the what-if situations and have an active plan in mind to help support them if they run into any question post-discharge. The final lesson learned is that the use of the dedicated case managers in the nursing facility really allowed the case manager to become embedded in the care team in the facility and better understand the processes of discharge planning, partnering more closely with the facility staff, but also being on site and being a resource to the member and the family really allowed those strong relationships to build, which ultimately ended up with more successful transitions occurring. Next slide. So my final part of the presentation this afternoon is to share one of our member stories with you. Bonnie, who you see on the screen right now, was living in the nursing home when she enrolled onto CareSource MyCare. A little bit about Bonnie. She had been diagnosed with a progressive form of MS, and prior to coming into the nursing home, had been cared for at home by her husband. Tragically, Bonnie's husband died suddenly, leaving her unable to manage her care at home. So she required admission to the nursing facility for care. However, through all of that, she never gave up her wish to live in the community. So upon enrollment into CareSource and meeting her case manager, Bonnie did share her goal of wanting to return to the community. Together, Bonnie and her care manager worked to develop a plan to support her goal of living in the community. What was very interesting for Bonnie is her biggest hurdle to transitioning really was being able to find accessible housing in the area that she wanted to live in. So that became the primary focus that Bonnie and her care manager worked on. Once that was identified and she had a safe place to go, Bonnie was referred for home and community-based services, and they worked to get other resources also in place, and she was able to successfully transition from the nursing home, and now she's living in an apartment and very happy, as you can see by the smile on her face, very happy to be living in the community again. We have included, when you receive the slides, a link to Bonnie's story. And if you have the opportunity, I really encourage you to watch Bonnie tell her own story in her own words. We've been very privileged to be part of her journey and are happy to share her story with you all. So that ends my part of the presentation. So I'll go ahead and turn things back over to Logan. Thank you.
Great. Thank you so much, Jennifer and Jean. And we have received a lot of great questions already, and we will try to answer as many questions as we can. And I encourage you, if you haven't had a chance to ask your question yet, then to type that into the question and answer box. And our first question that we'll ask for all of our panelists is if you can speak to when you've designed initiatives to address care transitions, what are some of the challenges that you found to be specific to dually eligible individuals? And how did your plan's respective program respond to those challenges that are related to this population? So I don't know, Lisa, if you'd like to take that one first.
Sure, Logan. It's a great question, and I think we had to make sure that we designed a program that would be a benefit to the member, that they would see it as something that would help them and that they would agree to allow this nurse to come into their home regularly. So we really had to make it member-centered, and I think our entire panel has talked about the importance of that. So we didn't want to become too clinical in our approach. We didn't want it to be simply motivated by reducing costs. We really wanted to personalize it and make it something that we would see high satisfaction with.
Great, thank you. And Amy or Jennifer or Jean, would you like to speak to that question of some of the challenges of designing care transition interventions specifically for this population of dually eligible individuals?
Yeah, hi, this is Jean. So, and again, I think several of us have touched on this as well, but, you know, particularly at CareSource and for others, we have different populations, different levels of care, and in some ways our members, there's a lot of fluidity in our members relative to their movement. And so what actually Jen and I spent several months a couple of years ago developing workflows, very detailed administrative and clinical workflows to sort of guide the process again and to make sure that there weren't any gaps in care. And what we have found is that you know, one time is not enough, that they need to be constantly sort of groomed and attended to as we learn new things, as administrative and clinical and regulatory requirements change. But we find it absolutely critical, and we had to map workflows in all different directions, from, you know, long-term care to community well, from community well to waiver, from waiver to long-term care. So spend some time doing the work up front.
This is Amy from Health Plan of San Mateo. I think for us, the biggest challenge is the fragmentation of this in the system and navigating that system. And so the way that we navigated that was the coordination and having kind of the point person or the quarterback in the case manager to be able to help navigate and coordinate all the services and all the people and care teams and all that good stuff.
Great, thank you. And next, we received a question asking about considerations for data infrastructure to share information between the plans and partners, such as home health agencies and housing agencies. And if you can speak to what has been most helpful in terms of developing or maintaining that data infrastructure and information sharing. I don't know who would like to speak to that first.
This is Jennifer. I can jump in, and it's a great question. I think that a lot of the work that we do, and specifically as it relates to our members who are living in long-term care, one of the things that we do try to do is have our care managers gain access to the electronic medical records for our plan-specific members. A couple of things that does for us is allow us to, you know, clearly review it from a clinical perspective, what might be going on, and then be able to access and use facility staff time, the professional services of the physician, the nurse, the therapist, the social worker in a more efficient manner because we've done our homework. It is a struggle. I can't say that we've developed a process that covers all situations or levels of care consistently. So a lot of the work that we do is development of the relationships with our providers, trying to identify and streamline by having that care manager being the primary point of contact, that it's the same care manager that's coming back. Our model is a little bit different, and in our MyCare space, we are 100% case managed. So we have those resources available to us, but it is a work in progress with the electronic sharing of information between the plan and providers.
Great, thank you. And Amy or Lisa, did you want to speak to that question as well on information sharing between plans and partners?
This is Lisa. Unlike the previous response, we actually don't have a sophisticated program for that. We have weekly staffings with our home health agencies, and then our coordinator for the program enters the updates into our internal EMR, but we don't have a sophisticated sharing yet. I'd love that.
Yeah, it's Amy from Health Plan of San Mateo. So we do data share, so we have access to our care partners' systems, they have access to our systems, and then as part of the contractual relationship, we do get regular reports on data, so that's been hugely helpful.
Great, thank you. And then next, we received a question, did you experience any challenges with engaging the members? And if so, what tools were used to engage members?
So this is Jean again. I can say that in the community well space, there's a significant challenge engaging members. You know, that population is typically, not always, but typically younger. They are somewhat healthier. They are certainly more mobile, and you know, they are, and we have a large severely mentally ill population. So they can be a real challenge. We dedicate, we call them patient navigators, but they're actually community health workers that, you know, will go out and, as one of the speakers mentioned, we will go out on the street, under the bridge, trying to find and engage members. We've got a fairly rigorous and robust outreach process for trying to reach members. We have done quite a bit of training, for example, on messaging and how to move members from no to yes. We find that members that don't care for us to visit with them in the home will very often agree to text messaging, for example. But I also think that and there are a lot of other strategies. But I do think that reaching out to difficult to engage members during crisis, during time of transition, you know, we always say seize the crisis, because I think members very often are much more amenable to support and assistance at that time. So, you know, perseverance, patience, a little bit at a time, trying all kinds of different approaches, including meeting members in the dialysis facility, leaving information on their doors. So we'll try just about anything that it takes.
Great, thank you. And Amy or Lisa, would you like to speak to that question as well on addressing any challenges with engaging members and any tools that were used for member engagement?
Sure, this is Lisa. Just like our last panelist said, we also rely on our community health workers. We have them assigned to neighborhoods, so they become very visible to that area, and they are very good at meeting members wherever they'd like to be. But I think at the end of the day, for our dual eligible members to say yes, it really comes down to the genuineness of why we're trying to work with them and what we're trying to bring to them that they want. And it takes some finesse to learn how to not to simply have our staff want to get the job done, but to make getting the job done really meaningful to the member. And we're still working on that.
And this is Amy. So, you know, we actually didn't anticipate this. We thought most folks would want to get out of long-term care or skilled nursing facilities, but not everybody does. So one of the things that we will often do is leverage the care relationships that they have. So whether it be with a facility, with a family member, just explaining what the program is and what it can allow. Taking the time to view where they're going to go and what that's going to look like, and having them be very involved in the planning. There's a little bit of an aspect of motivational interviewing, and then an ability to be flexible. If they're not ready yet, then getting them back into services when they are ready.
Great, thank you. And then we have a question specifically about iCare's program. So this one is for you, Lisa. How were home health agencies chosen for the Follow to Home program?
Great question, Logan. Originally, we approached the home health agencies that had the largest volume of our membership. And those two agencies did work with us in developing what the program would look like, the actual model. But at the end of the day, when it came to contracting with them, they both declined. And that really for reasons that they were part of larger health systems, and the health systems had, you know, it was complicated. I think the home health agencies wanted to work with us, but then people in finance didn't really see this as a win-win. So we wound up going to our community agencies, and we looked for those agencies with the best quality outcomes first. And I really think that this Follow to Home program has actually strengthened our relationship with the agencies. And but there are a couple that we don't necessarily want to work with just because of previous quality concerns. Hope that answers it.
Great, yes, thank you. And so next, a question for CareSource. How do your care managers work with hospital-based care managers if a need is identified while hospitalized?
So this is Jennifer. What we do when we have a member, and Jean mentioned our significant change event process, whenever we identify that a member is hospitalized, we have a process in which our care managers reach out within a 24-hour period to touch base with the member. And if they're hospitalized, oftentimes our members may not be able to speak with us as a result of their condition or the type of treatment that they're receiving. So we absolutely work very hard to connect with the hospital discharge planners. What often happens, we may have phone calls. Sometimes we try to visit the hospital to see our member, to make the connection with the case managers. Some of our relationships are extremely strong, and they reach out to us. Some of our hospital systems will call us regularly to let us know what's going on so that we can actively participate in discharge planning. Others, it's a little bit more challenging. So I think we, as Jean said, continue to leverage every opportunity that we have to bring value both to our membership but also to our health partners, our hospitals, so that they can see that we're really there to help in an effort to hopefully bring stability to the individual, help prevent a readmission, help keep them out of the hospital for greater than 90 days, long-term if possible, and link our members to the right services so that they are stable in the community.
Yeah, thanks, Jen. The other thing I would add to Jen's point, you know, our hospital partners also have their own outcome measures that they struggle to meet, and they struggle to place patients within the required time frame in a safe and supportive setting. And so, to Jen's point, we've done a lot of work in terms of working with the hospital systems in terms of we can bring this value to you. This can be a win-win situation. We both need to follow up with our members, and we can also help you achieve your outcome measures. We also have, we work with sister programs because we've got five plans providing, at least three providing MyCare services in our region. And so we've heard from the hospitals that we overwhelm them with requests for discharge planning. So what we've tried to do is achieve synergies where we can to sort of streamline all of the communications. So, for example, we will work with one of our sister programs who has an embedded case manager on the hospital floor. So we will work together with that embedded case manager to meet our needs, or we will establish liaisons so dedicated persons both on the MyCare side as well as the hospital side who are responsible for coordinating all of the communication. So again, we try and look for synergies where we can and reduce the abrasion, the burden that we place on hospitals, while also trying to convey to them that we can help you meet your outcome measures in the same way that we need you to work with us.
Thank you so much, Jean and Jennifer. And our next question is, we'll go to Amy at Health Plan of San Mateo, and then I'd welcome our plan presenters from other plans to chime in as well. And the question is, with regard to alternative housing upon discharge, what were some of your techniques for finding good, safe, alternative housing options?
Yeah, that's a wonderful question. So I think one of the things that we did is, leveraging Brilliant Corners relationship in the housing space already with landlords, setting expectations up front as to what safe housing could look like. And then I think working with our Department of Housing at the county and Housing Authority locally to determine if there were opportunities. So we have these senior set-aside units that actually we pay for some services on site, and we get our members who are enrolled in CCSP to jump the list. So they may have 179 new units or rehabbed units, and so we will get 10% of those or 8% of those, where they won't have to go through the normal process, because housing is in such high demand, they may get 1,000 applicants. So that's been hugely helpful for us too. And I think, on the licensed board and care assisted living side of things, doing quality assurance visits and reviews of records to make sure that they are really delivering the care in a way that we find as safe and effective.
Great, thanks, Amy. And Lisa, Jennifer, Jean, would you like to speak to that question as well on techniques for finding good, safe, alternative housing options?
Hi, this is Lisa. We've had really some phenomenal luck coming to embrace the Housing First model and finding local nonprofits that have engaged us in a way that they will prioritize our members when someone is in need of housing, as long as we provide really strong case management to prepare the member, and then they in turn take over the case management once they're placed. So I think it's really that investment in these community relationships and having CBOs that have resources that can help our members. We've been able to have our members get their past utility bills paid, and all those things that previously might have led to eviction. We've had a great success in partnering to eliminate. So I think you just really have to be in the community, understanding what leads to the housing instability, and really work on it from the ground up.
Yeah, this is Jean. I would agree with those comments. While there's never enough, in some ways we feel pretty blessed in Northeast Ohio relative to housing. But what I would say about that is that it's our dedicated behavioral health team that has really taken on the challenge of social determinants, including housing. And they have served as the housing subject matter experts for MyCare, and they support and consult the other populations and the other regions. So it's worked for us, and I rather than everybody trying to become familiar with housing, for example. It has worked for us to cite that within one population who then consults with everyone else.
Great, thank you. And this next question is for Amy. For health plans that are interested in diverting members from an initial admission to a nursing facility. It can be challenging to measure the impact on cost as compared to transitioning from a nursing facility to a community setting. So how do you address that challenge in measuring that impact on cost?
Yeah, that's a great question, and I think one that we've tried to figure out for a long time. So one of the ways we started doing it was more kind of we did it two ways, quantitative and qualitative. On the quantitative side, we do look for all of our populations, so whether they're in long-term care, in the hospital, or in a short-stay rehab, in a SNF, or in the community, the 6 months pre and post. And really the goal of the program was for healthcare costs to stay stable on the pre and post side in the community diversions, but actually one of the things that we've found is that healthcare costs actually decrease with the intervention. Which was an exciting and interesting piece of this. And then on the qualitative side, one of the things that we have measured is the number of community months that are generated, and essentially tracking those, because every community month generated is an avoided long-term care or SNF stay.
Great, thank you so much, Amy. And then a question for Jennifer and Jean. Can you share what you see as the most effective ways for health plans to partner with nursing facilities and share care management activities?
Sure. I think one of the things that we've been most successful with is within our population is assigning dedicated case managers and our patient navigator teams to specific facilities within the regions in which they live. We, in MyCare, cover a 12-county region. 12 counties make up our region that MyCare is found in. Within that 12-county region, we have approximately 300 nursing facilities. So within our case management models, our case managers, who are RNs and social workers, have a caseload of approximately 5 to 7 nursing facilities that they're responsible for. The navigators are a little bit spread more thin, but they're really an extension of the case manager and kind of give us bench strength when we need some additional support. So our case managers are in their buildings weekly. They need to go out, see their members. They're not seeing every member every visit, clearly, but we do definitely encourage them to be there. So in addition to focusing on our members who live in the facility long-term, working to identify those people who want to leave and go back to the facility, the other side of the coin is, I'm going to call it diversion. So we have members who are coming into the facility for short-term skilled services under their Medicare, the Medicare portion of their benefit. And what we want to do is, whenever possible and viable for the member, it's their plan, it's what they want to do, is prevent them from becoming institutionalized. So we really want to focus on what services need to be set up sooner in the stay, closer to the point of admission, which again requires the fostering of that relationship between the care manager and the facility staff. So I think that's an important element. One of the other things to consider if your plan is going to be working with nursing facilities in the long term, again, goes back to the idea of looking at medical record access directly, perhaps embedding that in contracting with your PAR providers, so that, again, you're using that information for a very specific reason to help support the members in achieving their goals. And it allows the clinical teams to work through what needs to happen in a much more efficient manner.
Great, thank you. And we have time for just a few more questions. So another question we received for all panelists is, what role, if any, did food nutrition play in each program to successfully help members stay in the community?
Hi, this is Lisa. Significant contribution. When we've analyzed the reasons for readmission, we don't miss the fact that poor nutrition certainly does not help. And if we don't actually know when the member's discharged, who in the home, if anyone, is preparing meals for them, how how well are they gaining access to healthy foods? As we've studied that, we have learned that our members don't have access to healthy foods. So we have begun a program of ordering meals post-discharge. And we've had really two astounding outcomes. One is that there's high member satisfaction with the meals, even if they only say, oh, I'll take one meal a day for a few days. I want to make sure I actually like it, to really liking it. And then two, we've seen that they're, oh, I just went blank, Logan. I'm so sorry. Oh, I'm sorry, the ROI, a significant ROI for the members who received meals after discharge. So we're a big fan.
Excellent. Thank you so much, Lisa.
Yeah, this is Amy. We do the same. We do something very similar, and that transition period is really great to have meals play a big role in that.
Great, and then we'll wrap up with a question for each of you. And we received the question of someone who's thinking about where to get started and is interested in hearing how each of you got started, and is there a format for needs assessment that you may recommend?
Hi, this is Jennifer. Oh, go ahead, Jean. Go ahead.
I had a clarifying question. And I don't know, is the questioner referring to a needs assessment relative to how to build a program, a dual eligible program?
Yeah, that was my interpretation of the question. I'm not able to clarify that, but I think it's really designed as a kind of for plans that may feel spurred to take action after hearing about some of these great programs. Do you have any insights or recommendations on kind of the best way to, and kind of some of the important considerations to think about getting started?
Well, this is Maya from Health Plan of San Mateo. Hi, I'm Maya Altman, and I've just been sitting in listening. And since Amy wasn't here when we started, I thought I'd try to answer the question. And, you know, we really, as Amy said in her presentation, we really saw a need in the community. I mean, it was obvious, you know, it was a facility about to close, we were losing beds, we were having a terrible time placing people. And then we knew that the dual demonstration was going to come along in a year or so. And so what I did was I hired a consultant who worked with me to go out to the nursing homes and just talk to them, because the nursing home isn't going to admit that people aren't at the level of care, don't really need to be there. But if you get in a conversation, they're going to say, yeah, maybe 10 to 30% of people don't really need to be here, but they have no place else to go. So that gave us kind of helped us quantify what the need might be. And then I think the other thing that was really important, what really helped us is we did have a program that was similar, not run by a plan, but run by the city of San Francisco nearby, that was trying to move people out of nursing homes based on a lawsuit, basically. And but we did, so we had that concept in mind, but we did a really, really detailed RFP. And that took a lot of research, but that made it helped us really define what we were looking for. And so I really am a big fan of doing RFPs. It's just a discipline for the organization itself to force yourself to define the problem really specifically and really well and what you're looking for. So those are just a couple of ideas about how we started.
Great, thanks, Maya. Any other final insights on how to think about getting started and defining the needs to be addressed?
This is Jennifer.
Oh, go ahead, Jennifer.
Okay. No, the one thing that I would point those who are interested in looking at some of the dual demonstrations that are currently happening now. For example, in Ohio, we've been around since May of 2014, and there's significant information available through the state that speaks to kind of the framework for the purpose and the outcomes to date across all of the plans that are participating. So just as a suggestion, that may also be a good place to start from in terms of research to identify, and just speaking of Ohio very specifically, the model that was introduced and how the demonstration was structured.
Great, thank you. And Lisa, did you want to add into that question as well?
Well, I would just say that when we began to design our programs, everything is analytics. We had to know where these readmissions were occurring, what was leading to them, and so that took quite a bit of time. But then I think also the value of not thinking that, look, it's up to you and it's got to be your staff that are the solution. In our case, my CEO was very clear. He said, Lisa, you're not getting more staff. Now, what are you going to do to stop readmissions? And that's really what spurred the Follow to Home program. So I'd say don't underestimate the interest community providers have in partnering with HMOs. I've been pleasantly surprised at how successful it is to approach nonprofits and say, hey, we have an idea for a program. Would you be interested in listening to our idea? And I will say resoundingly, they say yes.
Great, thank you so much to all of our panelists. And I'll just share a few final quick resources before we wrap up. And these resources may be helpful for those of you that are looking to dig in further on how to design care transition approaches for the individuals that you work with, and also for more background on opportunities to improve care for dually eligible individuals. So first, you can visit chcs.org, and that includes extensive resources, and you can also subscribe to updates or follow CHCS on Twitter to stay up to date. And then second, you can also browse the playbook for additional studies and implementation tools that are related to care transitions for high-need populations. And if you have established a promising practice, or if you've published on a complex care program, we would really encourage you to submit this resource to the Better Care Playbook, and you can do that by clicking on Submit a Resource and Contribute Now on the Playbook's website, which is bettercareplaybook.org. And finally, please fill out the evaluation survey that will show up on your screen at the close of this webinar. We really value your feedback, and that will help us design future webinars to meet your needs. So I want to close today by thanking all of our presenters for sharing such insightful comments about their programs and experience in developing approaches to address care transitions. And I also would like to thank the Commonwealth Fund for making this webinar possible. And thank you to everyone who joined us on the webinar today and shared great questions. Thanks so much.